Hello and welcome to the Clinical Care Options podcast. I'm your host, Zachary Schwartz. In this episode, we ask the question, how should we manage primary biliary cholangitis in people with high ALP levels? To discuss this, I'm joined by Dr. Nancy Reau at Rush Medical College and Dr. Stuart Gordon at Wayne State University. For more information, including slides you can use to follow along, please see the show notes. Now let's get started.
Hello, and welcome to this Curbside consult. In this case, we explore managing primary biliary cholangitis therapy for patients with high alkaline phosphatase. I'm Nancy Reau from Rush University Medical Center, and I'm joined by my colleague.
Hello, I'm Dr. Stuart Gordon from Henry Ford Health in Detroit.
All right, let's start with the case. This is a 45-year-old Hispanic woman. She was diagnosed with AMA-positive primary biliary cholangitis 2 years prior. Her baseline included itching, fatigue, dry eyes, dry mouth, Raynaud's, and on non-invasive testing, she had minimal fibrosis. She started on weight-based ursodeoxycholic acid after the diagnosis and did improve in her alkaline phosphatase at 3, 6, 12, and 24 months, but never reached normalization. And you can see here that she started very high with an alkaline phosphatase of 925, minimally elevated AST and ALT of 67 and 72. And after 2 years, she's decreased to 375 from 900 and really almost normalized AST and ALT, but did not normalize her alkaline phosphatase. So we debate a little bit on what normal alk phos is. Some use like 1.67 times the upper limit of normal, some use 105, but clearly 375 is not in any of these definitions. On top of this, she has not had any substantial change in her extrahepatic manifestations. So, Stuart, what would you be telling her?
This case raises several interesting aspects to the treatment of primary biliary cholangitis. I think a lot of us as clinicians didn't really look toward normalization, and emerging data is suggesting that we really want to bring these numbers down. The lower, the better. We used to be satisfied with improvement in alkaline phosphatase, but we really didn't sort of look at the magnitude of decline or what the long-term clinical significance of that magnitude is, or what normalization may mean to long-term outcomes. So I think that normalization is really not a realistic goal. I think that we're probably going to see somewhat of a plateau, but it's not going to change very much over time. And aside from the fact that there's different upper limits of normal, we're nowhere near normal in this case. And I don't think that continued therapy is going to be leading to normalization. So I think normalization is really not going to be a realistic goal in this patient.
Yeah, well, especially after 2 years on ursodeoxycholic acid therapy, not hitting normal, continuing what we're already doing is probably not going to go anywhere. And so we do have some data. So I think we've already talked about the fact that it doesn't surprise us that after 2 years, going from 900 plus to normal was just not really realistic. And then when we're discussing the window of when you would expect someone to improve, there's both futility and efficacy, right? So if I have a patient who has not had an improvement in alkaline phosphatase after about 3 months on ursodeoxycholic acid, I'm starting to worry now that this agent may not work for this patient. But I might still give them another 3 months, another 6 months to respond, especially if I started the ursodeoxycholic acid at a lower dose and tried to creep up because of tolerance, or maybe the patient missed a few doses. But certainly after 6 months or a year, if you've not seen any change in your alkaline phosphatase, you should start to think about second-line therapy. Is that also what you then do, Stuart?
Oh, yeah, absolutely. And especially as we start talking about this patient's symptom as well, we have rationale to begin a second-line therapy earlier. And I think also, as you mentioned, sort of high-risk groups, men in particular, which I think you'll be discussing, but I think this would clearly be a case where we would want to initiate second-line therapy earlier.
Absolutely. And so I think you kind of implied that PBC is not always predictable, and we do have some patient populations that are at higher risk for progression, and that does include our younger patients as well as men. And although sometimes ethnicity or race are difficult to pull out, I have seen more aggressive disease in my young Hispanic female population, so I'm a little more careful with them. I don't think they have autoimmune overlap, but you wonder if maybe the disease expression might be a little bit different in a younger population that's already showing signs of PBC. All right, so this study doesn't exactly answer the question about a high alkaline phosphatase at baseline, making it to normal, but tells us when the average person treated with urso kind of plateaus. And so, although in this study, people had an alkaline phosphatase that was much lower than our patient, the mean baseline was 292 and the upper was 480. It really was within the first 3 to 6 months that you saw a plateau of the alkaline phosphatase, kind of implying that just continuing to do the same thing and hoping for the best is probably not realistic. And the higher you start, the farther you have to drop. And so I don't think that it's going to be fair to expect someone who starts at 900 to make it to 105 or 120 after 3 months. But I would say that if my patient has dropped by significant portion at 3 months, I'm still going to watch them at 6 months. I'm not going to use a number as the set point, but rather a delta. If you're declining your alkaline phosphatase, I'm going to continue to watch you until I'm sure that there's a plateau. So from 1 month to 3 months to 6 months, if every single time you've come down, I may not be adding a second line agent at that point unless it's for another reason like extrahepatic manifestations. But if I've had two assessments 3 months apart and the number is almost exactly the same, at that point, I'm going to assume that I've reached the efficacy of my agent and probably start to discuss whether or not we need to add something. Is that what you do also, Stuart?
Exactly. And I think this gets to the point of individualizing care based on which patient is sitting in front of you. And I think this nicely articulates how we would need to specifically individualize in this case. There's not going to be substantive improvement over time in this particular case. So I would agree.
And so I think that we did talk about the fact that alkaline phosphatase expectations are different than goals. So your expectation might be different in someone who starts with a high alkaline phosphatase, but your goal is still normal. And would you agree with that?
Exactly. And I think as we start talking about the second line therapies, we really need to sort of put them in different buckets. Or we have different goals for individuals who are starting off with 1,000 alkaline phosphatase versus those who are starting off with 1.5, 2 times upper limits of normal. We're really talking about apples and oranges here in many cases. So I think it's important to individualize and have different goals and explain them to our patients as well. And so yes, individualized, and the treatment goal is very different for these patients with very high alkaline phosphatase.
But let's talk about our second line therapies. So we've already talked about the fact that a plateau is usually seen somewhere around 3 to 6 months with ursodeoxycholic acid. And we're going to go through some of the data, but also with our second line therapies. And so at this point, 2 years after treatment initiation, we have maximized our current therapy. So Dr. Gordon has implied that the new agents, the new PPARs, are probably good choices. And in the ELATIVE study, which looked at elafibranor through week 52, by baseline alkaline phosphatase, it really shows that if you start close to the goalpost, it's much easier to meet that efficacy endpoint than if you're starting really far away. Now, that's logical, right? But it's always nice to have data in front of you so that you can talk to your patient about expectations, so that if you go into your second line agent really far away from where you would hope to be, you are probably not going to make it across that line. Whereas if you start very close to normal, then it's much easier to kind of move you into that normal range. And from baseline alkaline phosphatase, that overall, those that were less than 2 times the upper limit of normal almost always made it into that normal range. And if you were greater than 4 times the upper limit of normal, only about 20% made it into that biochemical response. And if you look at alkaline phosphatase normalization, only 13% in that really high risk group. So again, it doesn't mean treatment failure. It just means that you didn't get to the alkaline phosphatase biochemical goal that you might have had if it was a one-size-fits-all. We have similar data with seladelpar. In the response trial, when they also broke down their efficacy by baseline alkaline phosphatase, you could see that those that started really much closer to a normal alkaline phosphatase achieved that at higher rates than those that started at a higher level. So that if you look at the individuals that had an alkaline phosphatase of less than 350, 76% of them on seladelpar achieved composite endpoint, whereas those individuals that had an alkaline phosphatase above this level, achieving that composite endpoint was much lower. So, Stuart, do you think that alkaline phosphatase normalization is the most important metric, or do you think that we actually achieve some efficacy in those that maybe don't normalize their ALP phos, or is there another number that you think is important?
Well, it's a good question, Nancy. There's been some interesting literature that's emerging showing that we really should be looking at the total bilirubin value, that the upper limits of normal may be a little less than what we're traditionally been taught, and that we really should be striving long term for improvement in bilirubin. It's certainly the most convenient and traditional and conventional to follow the alkaline phosphatase values over time, the slope of the curve, the trend toward normal, plateauing, et cetera. But I think that there's some interesting data emerging suggesting that the bilirubin may be important to follow as well.
All right, so let's turn to the study that looked at A-beta-cholic acid. Remember, in patients who had incomplete response to ursodeoxycholic acid, you could either receive placebo, an up titration of 5 to 10 milligrams, or just 10 milligrams. And they looked at the individuals who did not have the ALP target that was reached and compared them to placebo. They looked at 4 different markers: FGF19, which is a marker of XFR activation, CRP and IgM, which are markers of immune-mediated inflammation, CK18, which is a reflection of hepatocyte injury, and then FIB4 and EPRI, which are 2 standard scores. And they looked at baseline 6 months and 12 months. So you can clearly see from this study that whether you had an up titration of 5 to 10 milligrams or just 10 milligrams added to ursodeoxycholic acid, there was clearly an improvement in all of these metrics, and most remarkably, an improvement in FIB4 and EPRI. So this really suggested that if you did not meet the composite endpoint, there might still be expected improvement, even if our lab value didn't reflect all of that. So, Stuart, how would you use this data when talking to a patient now?
I think that you're showing important data that hopefully can translate to the newer agents, and that even though we aren't seeing a composite endpoint, which is, after all, somewhat of an artificial goalpost, we are seeing improvement in other parameters as well. And so I think that what we're pointing out here is that even though we aren't achieving complete alkaline phosphatase improvement or composite endpoints, we are still witnessing other parameters that do reflect improvement over time. Do you feel that way?
Absolutely. Now, A-beta-cholic acid is an FXR agonist, and so this may not translate to our PPAR agonist, but I think it's very encouraging to know that value like ALK phos may not be the only metric that is a measure of success. This is another study looking at the global PBC group, which considered individuals after 1 year of ursodeoxycholic acid by alkaline phosphatase and total bilirubin outcomes. This was nearly 5,000 patients with PBC from 15 sites in North America and Europe. And if you looked at the role of bilirubin and alkaline phosphatase, that obviously if your bilirubin was normal and your alkaline phosphatase was normal, these patients tended to do great. 97% 5-year survival, 10-year 89% survival without transplant, and at 15 years, 79%. But if you look at those individuals who had a normal bilirubin or less than 1.0 and an alkaline phosphatase that was still abnormal, greater than 2 times the upper limit of normal, after 15 years, they still had a 68% transplant-free survival. In comparison to those that had increased bilirubin but normal alkaline phosphatase, there was only a 39% 15-year transplant-free survival. And if both of your numbers remained abnormal, 24%, really suggesting that you don't want to be caught up in just one number, that you would like to look at things that translate into long-term outcome and not just a normalization. But those individuals had the subnormal bilirubin and an increase in alkaline phosphatase, that their outcome was still excellent. And this study should be applauded. After 15 years, they had significant treatment retention. In Group A, there were still 500 individuals out of the original 2,000. And in Group B, 228 out of the original 681. So, I think that we can really trust this data. Does this change how you approach your patients, Stuart?
It definitely does. We really strive toward improvement, bilirubin and alkaline phosphatase. And so I want to educate the patients, educate the provider. I think this is a very important concept that you raise here, that we're really looking at both parameters as we treat our patients.
Yeah, now that doesn't mean that just because your bilirubin is normal, if your ALK phos is still elevated, we shouldn't think about second-line therapy, because this is ursodeoxycholic acid monotherapy, which is really all we had when these patients were enrolled. But I think in a patient who has not achieved a normalization of bilirubin, this is a cautionary tale. All right. So our patient does have extrahepatic manifestations. So she had a lot of Sicca syndrome, fatigue, itching, but she did not have significant fibrosis. So we did offer multiple second-line therapeutic options. I think that Stuart already said that abetacolic acid may not be his first choice. What other things factor into your decision on which agent to start?
Well, I think these are exciting times here, Nancy, and both of the new PPAR agonists remarkably showed improvement in pruritus. And I think this is just such an extraordinary advance that these patients during the trial kept track of their pruritus scores by a number of different parameters during the course of therapy. They were blinded, the investigators were blinded, and both showed improvement in itch scores. And so this is such a debilitating symptom, often underreported in our patients with PBC. The ability to offer something to help the itching in particular is remarkable. So, regardless of biochemical response, if a patient is still itching at all, I would definitely consider the addition of either seladelpar or elafibranor in this case.
Thank you. Yes, I think we cannot underestimate the importance of quality of life. And, when we only had ursodeoxycholic acid, or when our second line approved therapy was abetacolic acid, which may detrimentally affect pruritus, at least in my own practice, I listened to my patients when they were complaining of fatigue, poor sleep, itching, but I really didn't have a lot of solutions for them. And now we are able to talk to them about the fact that they might feel better. After 2 years of ursodeoxycholic acid, she had no substantial change in her extrahepatic symptoms, even though her numbers clearly improved. So our patients do not necessarily mirror their labs. And when we consider fatigue, which is one of the big drivers in PBC, we know that fatigue is present in up to about 80% of our patients, and it might be related to pruritus and sleep. So that if you are itching all night long or all day long, this is going to affect your sleep quality. And if you're not sleeping well, you might not feel well in the morning. So pruritus is not going to be improved by ursodeoxycholic acid. Even there are patients that feel worse in their itching with UDCA. And then it's definitely runs a risk of being worsened by abetacolic acid. So because she's not had biochemical remission, she had ongoing symptoms. We've already talked about the new PPAR agonists. Would we change our management if her alkaline phosphatase was normal? So, Stuart, I'm asking you, she's itchy, she doesn't feel well. Would you still add a second line therapy if she had an alkaline phosphatase that was now, let's say, 120?
Yeah, it's a very provocative question that you ask, and one that's undoubtedly going to be raised in the clinics around the country and around the world. We don't really have specific data among patients who have completely normalized. Personally, what I would do is to consider some of these agents. So the fact that we have agents now that have shown to improve pruritus, I think would trigger me to consider the use of seladelpar or elafibranor with the hope that we may see improvement in ongoing symptoms. I see little to lose here and potentially a lot to gain, especially in terms of quality of life.
When we talk about monitoring and managing PBC, Stuart and I really emphasize that treatment goals are going to be personalized. So there are the biochemical measures that are really easy for us to look at, right? Labs are easy. They're kind of black and white. And we know that we want your bilirubin to be as normal as possible, definitely less than 1. And ideally, a normalization of your alkaline phosphatase, and certainly the composite of both is preferable. But we also have to understand that quality of life is strongly impactful for our patients. And we now have things that we can do that improve quality of life. So although our treatment guidelines emphasize using second line agents in patients who have not met biochemical response, I think you can hear from Stuart and I that we both are considering those quality of life measures like itching, fatigue as treatment endpoints also, and maybe that would influence our decision on treatment options. Key takeaways from this patient really should include the fact that alkaline phosphatase expectations are going to vary by baseline levels. So in a person who's got a really high alkaline phosphatase, certainly anything above 350, the chance of getting to normal with our current treatment options is going to be less likely than someone who starts at 350 or less. That does not mean that improvement in alkaline phosphatase or that our goalpost for the patient is going to change. We still would like them to be normal, but it might be less realistic in those that start really high. Improvements in alkaline phosphatase, though, still do translate to potential treatment outcomes. So even if your numbers get better, but not normal, you might have better long-term outcomes than a person who wasn't treated at all. If you had to pick one number to normalize, I think we have emphasized that bilirubin might have a stronger role than alkaline phosphatase, but certainly both alphos and bilirubin normalization are going to be the better expectation. And then don't forget that our newer agents do impact pruritus and probably sleep and quality of life. And so that sometimes we need to have endpoints that are softer in the extrahepatic manifestations and not just the hard lab endpoints.
Thank you. That was beautiful. And I think it really sort of nicely summarizes the goal of this session. Thank you.
Thank you to Dr. Reau and Dr. Gordon, and thank you to our listeners for joining in. To hear more podcasts on PBC, subscribe to the CCO podcast channel on your favorite service.